Good evening to everyone. I am Cosimo Pieri from Europa Uomo Italy, also part of Europa Uomo Europe. And with me is Tania Estapé from Barcelona, which is also with me organized this fourth webinar on active surveillance. We did last year 3 webinars on active surveillance. With many specialists, medical specialists, many testimonials, and many people attending. And these were put on YouTube. Why you will question why we do a first one? But the idea is that we thought that it could have been useful because for 2 reasons. One is to give the possibility to people to attend to something which could be a sort of the best of active surveillance webinars. So something shorter and which could give a general introduction idea and then motivate people to listen to the full webinars. And second, because we thought it could be been useful to do a sort of virtual roundtable, taking some clips, some video clips from different webinars and trying to create a logic conjunction between the specialist presenting the arguments. So now, let's say the first 3 seminars webinars were, let's say, related to early diagnosis, in particular active surveillance, how to coexist with low-grade prostate cancer with also maintaining high quality of life. So this webinar today is consisting of 5 parts. We try to select some clip. Obviously, it's a selection, so you will probably could have other questions, and you could go in our website of Europa Uomo or on YouTube to find the total answers, complete answers. Here we will cover, first of all, we will cover what is prostate cancer, the evolution of medical approach, and in particular active surveillance. With early diagnosis, any specific with active surveillance. Then we will put in evidence what we call the evidences of this solid treatment, type of treatment. And then testimonials, we select some testimonial speeches, and we will end with the view of the psychological aspect. In order to be effective, I will introduce the first 3 video clips, 3 areas, 3 arguments, and Tania, which is a psychologist, psycho-oncology, will introduce the 2 others, which are more related to testimonial and psychological aspects. At the end, we will do a question and answer session, but obviously everything is something that is going on activity. So you can give some question now, or we can discuss later, as you all know, Europa Uomo contact point. So now to start, I will introduce the first part of video. The first speaker that I selected is Professor Hein van Poppel. Hein van Poppel is Adjunct Secretary of the European Association of Urology, specific for education, co-founder of Europa Uomo, and chair in scientific committee. This introduction will give just, we selected the point where the area where Henrik gives the idea of the number of cases to Europe and the difference between of danger between different type of prostate cancers.
But today we know that 1 out of 7 men in Europe will develop prostate cancer, and it's the most common male cancer in the European Union these days. And I give just an example in Germany. Prostate cancer today kills more men than colorectal cancer does. In the UK, more men die from prostate than women from breast, which is not the case yet in Germany, as you can see. Now, do not forget that prostate cancer, although it is not killing like, for instance, pancreatic cancer, like lung cancer, and there is incidental prostate cancer in the general male population at autopsy in more than 50%, do not forget that the tigers, the bad ones, are responsible for 11% of all male cancer deaths are thus prostate cancer related, which is enormous. And we need to do something about it. But this makes also that we are feared about prostate cancer because it is still a killing disease. It's not a disease of old men that die with it instead of from it. And this has to do with the differentiation of the tumor. A tumor can look very much like normal parenchyma of the prostate, or it can be very aggressive, where you hardly can recognize that this is prostate. And this is the different Gleason, Mr. Gleason has made this classification from 1 to 5. And a pathologist, he will say the two most common grades in the specimen that he sees, in the biopsy or in the radical prostatectomy specimen, is, for instance, grade 3 plus grade 4, and this will then make a Gleason score of 7. Everything that is above 7 is bad. Gleason score 8, 9, and 10. Everything that is below 5, we do not even consider this to be cancer any longer these days. It's not even mentioned in the pathology reports.
Okay, now.
So you immediately understand.
I introduce the part where Mr. Popper, Dr. Popper, explain how we can try to differentiate between the treatment between the cases of prostate cancer, and in particular, he will introduce the concept that was started in the beginning of PSA, the antigen for blood test that was important at the beginning, but created also a concept of overdiagnosis.
Will then make a Gleason score of, if we would treat all these people, we are over-treating, obviously. PSA was introduced in the early 80s in Europe, and you see that what was the immediate consequence by PSA testing is a high number of more cases of prostate cancer were detected. So we have diagnosed people that some of them did not need to know that they had prostate cancer.
So you've seen that this concept of overdiagnosis comes out, and now I introduce another specialist that was presenting in the second webinar, Professor Chris Bachman, which is a very important role in active surveillance, was one of the visionaries and initiator of this strategy treatment, and he is part of the urology department in Rotterdam Erasmus. He will again explain about PSA and the concept about overdiagnosis aspects.
I can only start with telling you the story of screening and prostate cancer, because in the 90s we started with PSA. The PSA was an easy test. It was a blood test, and everybody could get their PSA from the GP or from any physician. So we introduced screening, and there was an enormous screening activity amongst Europe, a large randomized study, and that showed in the end that screening could reduce mortality. Unfortunately, it also introduced an enormous amount of recognition, diagnosis of these harmless and slow-growing tumors that Swain was telling us about. And that's what we call overdiagnosis. Actually, you're being diagnosed with a cancer. However, this cancer is harmless for you because it never gives you symptoms, and therefore you live with the anxiety because it has to be checked again and again and again.
So now we have seen more or less what is prostate cancer, which were the startup of this way to understand, and the first ideas of possible understanding of the early diagnosis. Now we will go more in details about the aspects of active surveillance, what it is, what is this type of strategy of treatment, and we will see also the way to control, because this is a decision, and this is a decision of a strategy in alternative to other treatments. So we will start again with Andrew Van Poppel, which is now giving the idea of what is the basic concept of active surveillance.
So there must be a possibility to recognize which patients could just be observed without treatment. And this is what we call active surveillance. But this indeed means you are under surveillance. This is not nothing. You need regular monitoring, doctor visits, you need to have a delayed invasive treatment if there is tumor progression. But it's the only strategy to diminish the overtreatment of minimal cancer.
Now we have to even also Mr. Van Poppel was explaining the use of different treatments, and in particularly active surveillance, and pointing out they say that is a treatment which is in theory easier because there is no physical treatment, but in the same time is more complex because it requires a long work during the years with the patient.
Active surveillance over the last 10 years has continued to increase. Luckily, for low risk, ADT is less and less given. Still in 2009, far too much. This is a disease that should not be treated with hormones. There is still an increase in radical prostatectomy and radiotherapy.
Okay, now Mr. Van Poppel explains the criteria that are used to manage, to define with patients the journey, and also the importance of being able to be ready in every part of the active surveillance strategy to turn to the active treatment in case it's needed.
Quality of life, as shown by your team in Europa Uomo, is best when a patient is on active surveillance. So how can we eliminate the second most killing cancer without having any problem and not forgetting that there is active surveillance? We need to use PSA properly, and we should treat actively with radical prostatectomy or radiotherapy those at risk to die from prostate cancer, and manage with active surveillance those with low and part of those with intermediate risk. And this will decrease the cost of prostate cancer, decrease the mortality, and improve the quality of life. So
now we thought to select the information, the view of Chris Bachman. As we said before, he is a visionary of an auto experience about active surveillance, and in particular he is explaining all the arguments that were used to consider also the avoiding overtreatment or using the right way when needed to go from active surveillance to active treatment.
And therefore active surveillance was invented, and it had to be done in protocols because we did not know the behavior of all these tumors that were diagnosed but were Gleason 6. They did not seem to be aggressive. So this was overdiagnosis, but this overdiagnosis also introduced overtreatment, and that is a little bit the Atori story. There was a Gleason 6 tumor, and it was operated upon with side effects for many, many, many years. The same was for radiotherapy. And these side effects, of course, were unnecessary if you looked at the biology of the tumor, because you could have lived a very long time and maybe forever without an operation.
Now we will give another view to classify prostate cancer tumors, and then when gives also the idea when it's possible to apply active surveillance.
But everybody is familiar with the fact that there are multiple, let's say, aggressiveness levels of these cancers. And some of them, they act like slow turtles, and others act like birds. You cannot catch them. They are very aggressive. And whatever you do, even if you try to screen them early, they will result in metastatic disease, and you will die of it. And then there's a large part of tumors in between that grow. They need to be treated because they will become symptomatic before the end of your life. But unfortunately, you will suffer the side effects of that. We are talking about the turtles, the very slow and non-progressive cancers in prostate cancer. And when you have such a cancer, what happens?
As was pointed out, we are speaking about the cancer, the levels that can be treated with active surveillance. So these are slow progressive tumors. In this case, again, Professor Bachman went in details on the criteria of applying active surveillance, and also the criteria to go out from active surveillance when is needed.
The other question, how do we detect the cancers that might be amenable for active surveillance? The most important is the information of man. To tell the patient that what is his risk for having prostate cancer, and when he finally has prostate cancer, that it might well be that you're not going to treat him. Because if the patient does not know that beforehand, he will say, you detected cancer in my case, and I want to have treatment, I want to get rid of it. But he must understand from the beginning, from the initial information, that there is a likelihood that he can go on active surveillance.
Okay, so we have seen that active surveillance has a very knowledgeable protocols and very active, very careful protocols that can manage the journey of the patient, leave him in active surveillance when it's possible, and be ready to go to another type of treatment when needed. Now, let's say we wanted to show, we selected some clip from Monique Robol, which is a professor in Erasmus in Rotterdam, and is in particular is epidemiologist. So Monique was very was doing a lot of work starting from the 90s, and it was very important work because at that moment it was not clear if it was possible to use a technique or strategy like active surveillance. So now we will go in this video for this part.
So this is the reason why we started the European randomized study of screening for prostate cancer. It started in 1991, and you can see that over time, approximately 260,000 men have been randomized in Europe in 8 countries to a control arm where we do virtually nothing, only follow up. We see what happens to these men in daily clinical practice. And we had an intervention arm where we actively screened these men with the use of the PSA test and the TRUST-guided systematic prostate biopsy. That there was a lot of prostate cancer around, and that there was prostate cancer that never causes any problems, and that there was no difference between treatment and surveillance already. So already at that time, we realized that when we started active searching for prostate cancer, it could very well be so that we would detect a lot of prostate cancer that would not harm the patient if left undetected and untreated.
So from these few clips, you understand that you can have a glance that active surveillance was studied very carefully with very important data. So what we are using now is a sort of, we are using experience done in tens of years. What is important, obviously, once we know that is a very important effective technique, important is to speak with the patient, because obviously the patient is especially at the moment of diagnosis, can be in a very in a situation where he is a little confused.
And that is something that obviously refers to active surveillance. But then immediately comes the question, what is the risk if we do not treat actively with, for instance, radical prostatectomy or radiotherapy? Because it's a very strange message often to men that you tell them, let's say in one consultation, okay, I'm sorry to say this, but you have prostate cancer. And the next sentence is, but we will not treat you actively. That is a strange message, and people will start worrying and thinking, okay, what's going on here? And then immediately, obviously, the good message of active surveillance must be there.
So in order to give this, this is a very important aspect that needs to be put in front of the customer, of the patient, in a very clear and important way. And now, another point that gives validity, gives relevance to this technique is the fact that, as we say, there is a control, is a journey, is not a one-shot treatment. So Monique now gives the information, the idea of how this is handled by the specialist.
I take this example of the prior study. Perhaps you have heard of this. This is a global study. And what it is actually a very interactive website to which all urologists worldwide can have a login and use this interactive website to follow their patients which have opted for active surveillance.
Okay, now let's say we leave Monique, and we selected the clips from the presentation of Riccardo Valdagni. Riccardo Valdagni is an authority, at least in Italy here, is particularly in Italy, but also all over the world. He is part of the community which started actively to propose active surveillance. And in fact, since 2003, has been managing the prostate cancer program in National Cancer Institute in Milan. So obviously a lot of experience. And what we asked to Riccardo in that webinar is if active surveillance can be confusing for patients and how to avoid this aspect.
The answer derived from my experience is that patients should receive clear, unambiguous, balanced information about three critical points. At first, that low-risk prostate adenocarcinoma is not a malignant disease, and that the reason why active surveillance is proposed as an option at the same dignity level of radical prostatectomy and brachytherapy. The second critical point regards our, and I mean clinicians' language that should be evidence-based, based on national or international guidelines. And the third point is that the decision of of active surveillance among the other three treatment option is more complex than the usual decision-making process in medicine. Being, as we know, the three radical therapy equal in terms of oncologic outcome, as we will see, but not for patient risk of side effects.
So, in particular, the question now we put in the second question was how to choose between the situation, how to support the patient and create this connection and effective decision moment with the patient.
The answer is to share the decision-making process with our patients, and the choice should be the result of this shared decision process. So the problem is now how to choose the right option. In medicine, we know that is a linear path. The patient asks clinician, and in general, clinician prescribe the patient with the optimal therapy. In prostate cancer, the scenario is more complex. The clinicians having more options to propose, not to prescribe the patient, should suggest the patient the possible therapy or strategies for him, and then, and this is not enough, and then he should explain the treatment-related side effects in terms of quality of events and quantity. I think the message for patients is be an empowered patient. And from a practical point of view, do not delegate your decision to clinicians or relatives, as we as physicians see sometimes, the pressure or of the relative to choose one or the other of the option. Another important point, if anxiety is a problem for the many reasons that we have seen, ask for psychological or social support. Search for multidisciplinary prostate cancer center or units because it's the optimal way to manage the possible physician bias and minimize regret. And ask to be supported by patient association like Europa Uomo, that is really fundamental.
After this fast indication from Riccardo Valdani, we selected some indication of Professor Chris Bachman, which is going in the same direction and explains and points out the aspect of personalized treatments, which is related to all what we have seen, and which is now more and more the most important aspect when the multidisciplinary units in the hospitals, the specialist meet the patient immediately after the diagnosis.
We have checks and controls, and we are getting into risk evaluation that is personalized. And this is what we are working at in Europe at this moment. That is a personal risk assessment. As you can understand, the MRI in the one person is not the same as in the other person. And the PSA decline or increase is not the same. We are not the same people. Like we're sitting here, we all have our individual stories. These individual stories are full of individual risk elements. And we would like to say to the one patient, okay, you need a biopsy next year, but to the other patient, you can wait 5 years with your biopsy. And that's exactly what we want to accomplish with a personalized risk strategy.
Okay, as with this, we finished the third part of this selection of video clips. Obviously, as I said at the beginning, this is a selection, and this is the selection from one side gives an overview, and from the other gives a motivation to further understand. As I said, this is a selection, so you can have also a look on all the complete webinars. Now I will leave the speech to Tanya. We have the other two parts, which are related to selection of patient testimonials and the selection of the indication that was given us from Lara Bellardita, the specialist.
Hello, let me introduce myself. I am Tanya Estepe, clinical psychologist, and happily recently elected as a board member of Europa Uomo. That is a good thing, I think, for two reasons. One is because I am a woman, the first woman that's part of the board of Europa Uomo. And the other positive thing, I think, is because I am clinical psychologist, psycho-oncologist working with prostate cancer patients from 2000, I think, and that may give a different point of view to help to improve quality of life of cancer patients. And I want to thank Cosimo to have shared and have done the main work to build up this webinar. Now, as he said, we have testimonials. That is very interesting part. We need to have the voice of the patients, and we are beginning with Ioannis Vanezos, who is from Greek and a very kind person and part of the board member of Europa Uomo. I think he and Cosimo and me can also give the point of view of Mediterranean culture that is different from some other countries.
Go on.
Good afternoon to everybody, and it is my pleasure to be with you and have this opportunity today and share with you my medical journey towards reaching the active surveillance. As Cosimo indicated, my name is Ioannis Vanezos, and I am of Greek Cypriot nationality and right now based in Cyprus. When my PSA jumped about 10 years ago, my local urologist requested an MRI and then a biopsy, resulted in a Gleason score which was too low, 2/3. As I was traveling, before this time, before I took any decision, I have checked with specialist urologists in Cyprus, in Egypt, in Dubai, in Bahrain, and then the theater started. Every doctor, depending on his specialty, he was recommending his way of treatment. That, based on my previous experience, I took it very calm, very simple, very, very slow to my decision. And I have decided to go for the proposal that I have got out of one doctor from Dubai and one doctor from Cyprus, that they have suggested active surveillance. Believe me, I was very much confused. I can tell you honestly, with my hand on my heart, that I wish on that time that I knew the existence of Europa Uomo. I think they were just at the beginning at that time. We were depending on information we were getting from professionals, from people that they have the experience, and even from some patients. Now, you will ask me, Ioannis, what is your, let's say, resume out of this journey? Awareness and early detection, is the pillar to start your journey. And we all know the fantastic work Europa Uomo are doing concerning the above two pillars. Being on active surveillance for some years, I think I have only one concern. And this is the very simple expression: when the beast will wake up. My major problem is the psychological stress, and I'm very happy that today we will talk about the psychological stress. Till now, I have to admit that it's shown that it was a perfect decision. But at least today, I know where I am standing and what I can expect if things go the wrong way. In spite of normal aging health complications, at least I am enjoying a normal family life. My major headache is the bloody MRI and the agony till the results are written and given to me in my hand to give it to my urologist. I say to myself, okay, Ioannis, you escaped it once more.
Okay. Now there is Train.
Okay.
Now is Train Thomason is our friend of an association from Iceland, and I selected some part of his.
Active surveillance has made a huge impact on my life. If I had not chosen active surveillance in 2005, my life would most likely have been different, and I would have missed considerable quality of life. My active surveillance is a little bit special. I started PSA testing over 20 years ago in the year 2000 when I was 56 years old. No reason for starting. I just read in a paper that PSA blood test could be of importance. But my PSA value had reached 10 and I needed to have a biopsy. The result was that I was diagnosed with prostate cancer with Gleason score 6, 3 plus 3. Second opinion showed the Gleason score 7, 3 plus 4. I asked the doctor what to do. I booked you for a surgery next month, was the reply. At that time, almost all men diagnosed with prostate cancer went into treatment. The second question is the importance of second opinion. I think it's most important to get different opinion in diagnosis, not least when decision has to be made that can affect the quality of life of the person in question.
So now the third testimonial is from myself also, because I am under strategy of active surveillance since 2017, and till now everything confirms it is stable. So the treatments were the surgical prostate removal or the radiotherapy. And one was the strategical method of control, as we say, as I knew in that moment, called active surveillance. Together with the urologist, we find out that due to the general situation of the patient, the age, and the grade, which was low grade of prostate cancer, active surveillance could be the most logical choice. Also, the urologist alerted me immediately that there are possible psychological issues that because many patients do not want to keep the cancer inside their body. Here, what I want to say that in this approach, even if it was only one doctor, only one urology, the approach was multidisciplinary. So it was a very good approach, in my opinion, from the urologist, because he didn't push in one direction or the other. I think I was, say, lucky to find an association like Europa Uomo in Italy, because it gave me the two possibilities. One, to understand more about my choice. And the second point is the auto help groups, because in our association we strongly support the auto help group. Patients meet together, they speak together. These will have the shared experience, suggestion, so psychological support.
Well, we have listened to these interesting testimonials. We have some things they are pointed out that are very interesting. That is for our basic knowledge. We feel that if you have cancer, you should have it remain removed from your body. And so this is a very difficult exercise to take this decision to live with the cancer, because it's not fear of recurrence, but fear of progression. Because every morning, as one patient of mine told me, you wake up knowing the cancer is inside you. And I think they three have explained it very, very interestingly. And Ioannis have pointed out at the difficulty of having information and the dangers of navigating for the search on Google, because you can have good information, but also information that is scaring. So it's good to be careful with the information you have in the web. And the last video is from Lara Belardita. Lara Belardita is a colleague of me, who is a clinical psychologist, psychotherapist, and PhD in psychologist. And she is very focused in health, psychology, and behavioral medicine, and has a long-standing experience in collaborating with prostate cancer unit in Milano, Italy. And her research and clinical focus has been on psychological implications in prostate cancer, but interestingly, lastly, she has focused on active surveillance, because active surveillance is a focus very important for psycho-oncologists, because as the testimonials has said, the fact of not having the consequences of surgery, for instance, may lead other consequences, for instance, high anxiety and impairment of quality of life, because these thoughts or feelings that cancer can come, or you have the cancer inside. She has developed also specific interest in healthy lifestyle and health promotion, together with quality of life and, of course, psychological well-being. And for me, it's a pleasure to present her to say to men that if some patient needs to go to a psycho-oncologist, is not because he is crazy, but perhaps needs some help to cope with the situation of anxiety because you have the tumor inside.
So specifically, how does active surveillance impact on quality of life from your experience? What are the psychological implications?
But anxiety, the base of anxiety is fear, and fear is good because it's a primary emotion that is related to survival, that allows us to survive. We need fear. So it's good to have a little bit of fear, because that fear brings us to take things seriously. And being on active surveillance has to be taken seriously. Men have to be compliant in monitoring their disease. They have to be proactively involved in their journey, as Professor Valdagni was saying before. So we shouldn't say that anxiety, a little bit of anxiety in active surveillance is evil. It can be useful. We need to know how to deal with anxiety and somehow monitor the psychological state just as clinical parameters of prostate cancer are measured and monitored throughout active surveillance. So it is very important that the journey is a family journey from the beginning. The decision-making process has to involve the partner, the spouses, because again, it is something that affects the psychological well-being of the entire family. You need to talk to the patients, and together you need to find the right solution, find the right path.
No, it was very clear, your presentation. Another subject that we cover sometimes is the lifestyle. So what is the importance of lifestyle for patients in specific with active surveillance?
Active surveillance can be considered in some way in a window of opportunity, because men become patients, but at the same time, they're not sick. And so it's a good time to become proactive in learning about overall health, learning about disease prevention, other diseases prevention. So if you're choosing active surveillance because you want to maintain your health-related quality of life, you should be thinking prospectively and thinking about, you know, well aging, healthy aging. And healthy aging has to do with stress, has to do with sleep, with exercise and diet. All these factors, this is very well known nowadays, impact the body ability to fight illness and promote health. When it comes to healthy behaviors, exercise is the bottom line. Everyone should keep moving, and that particularly applies for men with prostate cancer on active surveillance, and generally for men with prostate cancer. And the indication is exercise as much as you are physically able. We can start by mentioning the functional aspects of quality of life, and we do know based on literature and based on also my clinical practice that compared to patients that go that choose active treatment, patients on active surveillance are more likely to maintain health-related quality of life in terms of erectile and urinary functions. But when we talk about health-related quality of life, we're not talking only about functional aspects. We're also, of course, talking about mental health. We're talking about coping strategies. We're talking about post-traumatic growth. So there's the umbrella is very large, and a lot of different factors fall under the umbrella when we talk about quality of life, health-related quality of life.
We have listened to Lara. That is very interesting to learn to cope with active surveillance and take the advantage of its benefits, not to have the prostate removed, no problems, erectile problems, no urinary incontinence, but sometimes anxiety may interfere these advantages. And anxiety is not good, as she said, when it interferes with health behavior, when it's too high, when it's too long. But if not, a few anxiety may help patients to be proactive, engage in exercise, in diet, and a healthy lifestyle, and take the benefit of have the active surveillance as a non-aggressive treatment.
So I think Tanya gave a very important indication about what we have seen is a testimonial, and with our friend Lara, psycho-oncologist specialist. So now we arrive to the end of this virtual roundtable, let's say. We hope it has been useful. Obviously, as it was a selection of elements, it cannot be totally complete. It could have opened some question, and that is good, because you can have material, you can go and have a full view of this presentation or other information that you can find on the website of our association, local association, through the 27 countries, or in the central website of Europa Uomo Europe. We are constantly trying to understand the needs of the patient, go over. So we do something which it can be tactical work, like supporting the multidisciplinary ward. Active surveillance now is a tactical application, a tactical way, and auto help group are also tactical way. We are also, as association, looking to strategy, because we are today looking what could be the need of tomorrow. So, for instance, the fact of having early diagnosis, which is the basic of improving the quality of life, as we did and we did some survey which have been put on the European community, and which are one of the elements that is supporting now the guidelines of the European community of having early diagnosis all over the countries in Europe. This is improving quality of life, and obviously as another aspect that is reducing the cost of, because obviously supporting a patient with the first spot action is a lot less expensive than supporting patients with metastases, which requires long and expensive treatments during many years. So having said that, I hope it is useful, and we can open question and answers, and hoping that you can give us some good questions, so that we can try to answer at the now or in the future with through email or other aspects. Do you have some questions, Anya?
Not in the chat, Cosimo. So if someone wants to ask a question, don't hide back, please.
This, in any case, while we wait for possible questions, this webinar will go on our website. So the idea here for this one in specific is to create an opportunity for people who want to have a fast overview of the items, of the arguments, and so as I said, is a selection, so it gives an overview, and could be the way to have a first glance that could be further motivation.
Cosimo?
Yes.
If you allow me for 1 minute only.
Yes, please.
Thank you very much for the summary that you have presented to us of the previous 3 presentations. It is true, and it is a fact, talking with people and with organizations, that they were extremely interested for the active surveillance approach that we took as Europa Uomo. But I believe to go through the 3 video or through the 3 recording, it was a little bit of quite a lot of time consuming. So it was a great idea to summarize it all in a new presentation of 50-55 minutes. And I would say it was a very important to keep the subject on the top and to refresh it every now and then. And I hope that in the future we will have one more with a little bit of the latest development from a professor or from more specialized people about the latest news and updates on the active surveillance. And I believe our quality of life report that it is coming in July to be presented, it will give us more push to go for it and to have a latest update on the subject. Thank you very much.
Thank you.
Cosimo, there is a question in the chat.
Okay, I will have a look.
How often should PSA be done?
Well, I can answer from my experience, which is also coming out from the information that I got from all these webinars. And first of all, you saw that there is a long data. There are a lot of data that the specialists collected since the year 90s, and this is the way they understood which guidelines should be applied. In particular, Monique Robol presented the PRIAS study, which is a website devoted to specialists. They can correlate the data of their specific patient with the total database, and so they get a guideline on things. Normally, it's the active surveillance is, as in my experience, as some important steps which are related to RMI or biopsies, especially in the first years, and then depending on the situation of the specific cases, there are more RMI or more biopsy or less. What is the standard in the journey of the patient in active surveillance is the PSA. The PSA is not something that gives the information of PSA as an absolute value is not a cancer evidence element. PSA is more an element of ongoing situation. So, for instance, if you have a stable PSA, it's a good information considering it is low value, but it's better to have a stable PSA than a growing PSA. In active surveillance, where the cancer is inside the body, as we say, it cannot go to zero. But in fact, the specialists go look after this carefully if it doesn't grow too much. But in a certain sense, to answer specifically, the timing is 6 months. So every 6 months, you do a blood test, which is a PSA. There are other questions? I don't see other. Oh, no. Okay, I see another question regarding the ADT treatment. That is obviously, as we saw, apart from starting and suggesting and choosing with the patient PSA active surveillance, you saw in many of the clips or the video clips that there is a constant attention to the situation. So while every urology hopes that active surveillance goes on forever, they have important way to understand if there is the need to change treatment. So it's like a sort of emergency that we as patients do not see, don't want to see, let's say. We hope that every urologist will say, yes, you go on. So when we do the visit, which are not, the visits are normally 1 year. So you do PSA every 6 months and you visit at least 1 year. So we open, but the specialists, as you see, have important tools and guidelines to be able to to put the customer, the patient, in a way to decide a difference between what they are to choose to consider the move to active treatment in case. Obviously, the information we saw in these videos are all related to active surveillance. When you move to another type of treatment, you normally need to go to urology if it is surgery, or to radiotherapy, or to oncologist. So in that case, you will be put in contact with the right specialist, and this is the important point also of the multidisciplinary units. We are pushing for patient to go since the start, since the beginning, to a multidisciplinary unit, which are normally in many health centers. Because if you are in a multidisciplinary unit, you have the more important, you have a high high safety, because you have you are under maybe active surveillance, hopefully, but you know that whenever there is a need, you will be in the same effective treatment way with other specialists.
One very important point, Cosimo, that we have to repeat it every now and then. We are patients. We are not doctors. Every patient should check with his direct doctors and to get the professional approach from a doctor, from the right direction. We, as Europa Uomo, we are patients that we give to our colleagues the information and the experience only that we personally have. For each and every individual patient, there should be a direct contact with his doctor.
Good. Yes, in fact, we are mostly giving information, but not we are not doctors. This is also good because, for instance, when our mission is to present the needs of the patient, which sometimes are say seen as important, but the doctors are mostly related to take out the cancer or treat the cancer, but sometimes they forget that there are side effects, and in the same time, especially for instance for early diagnosis, the doctors are very good in treating, but if we as patients are able to avoid some type of treatments, it's a lot better for all of us. Okay, so I think we are at the end, and I don't see other questions. Thank you for participation. I hope it was useful. It was, as Giovanni says, it was the first time we tried to do this way, to put together this review. So something could have been maybe better, but we tried, and we hope it is useful.
It has been an excellent idea from Cosimo to take advantage of previous webinars.
Okay.
Thank you to all.
Thank you. Bye.